morning from ACC. My name is Garrett Welle, and I'm accompanied by Dr. Javed Butler, Distinguished Professor of Medicine at University of Mississippi and um, uh, Director of Research at Baylor Scott White. Thanks for joining us, Dr. Butler.
My pleasure.
Excellent. So this morning we're here to talk about the EMPACT-MI trial, and to start off with, Dr. Butler, can you give us a quick summary of the aims of the EMPACT-MI trial and what we're looking for here?
Yeah, so EMPACT-MI trial was a streamlined trial that assessed the effect and safety and efficacy of empagliflozin in patients with acute myocardial infarction, both STEMI and non-STEMI within the first 14 days of myocardial infarction. What I mean by streamlined trial is that we really had only one in-person follow-up. Everything was remote, little data collection, and we had no central adjudication committee. So it was site-based sort of declaration of what the endpoints were. But because we did not have central adjudication committee, our primary endpoint was all-cause mortality, not cardiovascular mortality, was all-cause mortality and heart failure hospitalization, not all heart failure events. So we did not have outpatient heart failure in the primary endpoint. So all-cause mortality and heart failure hospitalization. These patients, if they had heart failure, they were excluded because they already have an indication for an SGLT2 inhibitor. So these were the patients with MI without history of heart failure who either had congestion, they could have totally normal EF, but they had clinical congestion, or they had a new drop in EF to less than 45%.
Excellent. Diving more into the STEMI and NSTEMI populations in this trial, I think it's important to highlight kind of how these groups translate to the risk of the study population.
Yeah, so that's very, very interesting. When I was at your stage of my career, patients with actually non-STEMI had a better prognosis than STEMI because at that time, it's not like we were doing angioplasties on everyone. Streptokinase was given or TPA, and that was not available, and people were getting, several hours late or whatever. So STEMI had worse prognosis than non-STEMI. Now it's completely a different sea change, right? So STEMI people come in, they have lipid control, antiplatelet agents, all the other drugs and whatnot. But the biggest thing is you get revascularized pretty fast. So most of the STEMI patients actually have a better prognosis than non-STEMI patients. That's one thing. The second thing is that if you look at the real world data, there are far, far, far more non-STEMIs than STEMI patients, right? So there's non-STEMI is more common. Except that when we do clinical trials, you usually go to sites that are, high cardiology sort of sites that participate in clinical trials. So in the clinical trials, you end up getting 3/4 of STEMI and only 1/4 of non-STEMI. So these are the things. So in our trial, also in the placebo arm, there was almost a 35% higher risk, 8 versus 12% annualized event rate in STEMI versus non-STEMI.
Yeah, it's fascinating. For some of the pragmatic differences in the trial, you mentioned how this trial is streamlined, trying to make it more pragmatic. Can you highlight some of those additional pieces of the trial design?
Yeah, so there were 3 or 4 things. So one, our inclusion exclusion criteria were really very broad, pretty much all comers. So you did not have to go and do some special test or something or blood test. I mean, it was just basically all comers. Bottom line, with STEMI or non-STEMI, diabetes, no diabetes, doesn't matter, as far as they have congestion or drop in EF. So that was one. The second is that the data collection was very focused. So sometimes we collect all of these extra data, but it was like really just bare minimum that we needed to know to understand the results. So that was the second thing. The third thing for the streamlined trial was that we had barely any in-person follow-up, just one follow-up. Everything was remote to make it easier on the patient. And then the fourth, as I mentioned, there was no clinical events committee. It was all based on site-based assessment.
Thank you. So in EMPACT-MI, I mean, not too long ago, DAPA-MI came out. Can you highlight some of the differences in EMPACT compared to the DAPA-MI trial as well?
I think there are basically two big differences. So in DAPA-MI, patients with diabetes were excluded, and we included patients with diabetes. So maybe a little bit of a different risk profile was one thing. And then the second thing is that DAPA-MI, for various logistic reasons or what have you, the primary aim was changed from a mortality morbidity trial to a 7-point win ratio that was more sort of targeted at the cardiometabolic risk factors and symptoms and stuff like that. So couldn't get to the heart of the question, which is the mortality morbidity post myocardial infarction from a cardiovascular lens.
Very good. Thank you. And then importantly, can you highlight or go over for our listeners the outcomes of EMPACT-MI?
Yeah, so our primary endpoint was all-cause mortality and heart failure hospitalization. There was a 10% relative risk reduction that did not reach statistical significance. If you look at the two components of the primary endpoint, all-cause mortality, there was no difference, but heart failure hospitalization were reduced by 23% relative risk reduction. The curve started separating early, continued to separate, sort of the usual feature that we have seen with SGLT2 inhibitors. If you look at the total heart failure hospitalization, first and recurrent combined, there was a 33% relative risk reduction. Again, very consistent with the other data as well. Now, one sort of issue is that the average time to development of heart failure was about 3 months or so, and subsequent to that, there was less than a year, shy of a year follow-up. So we didn't have, in this particular patient, enough of a follow-up to start looking at the mortality differences per se. That probably impacted our overall mortality results as well. Now, outpatient heart failure, though, was not collected as part of the primary endpoint. The sites did tell us about the outpatient heart failure. If we do include that in the primary endpoint, then there was a 37% reduction in total heart failure events. And actually, from an exploratory perspective, all-cause mortality and heart failure hospitalization was actually statistically significant, 21% relative risk reduction overall. No safety concerns were seen. So that was sort of the overall results.
Excellent. Thank you, Dr. Butler. Appreciate you coming and spending time here speaking on EMPACT-MI. And to watch more videos like this, please check out youtube.com, FITsOnTheGo, and follow us on X at FITsOnTheGo.